Hey everybody, welcome to week 7. We are going to go through 2 lecture PowerPoints today. So let me just pull up my screen here for you guys to see. No. So we'll start with the one with infections of the respiratory tract first. All right, so beginning with the lower respiratory tract, just a quick review. Respiratory system in general will consist of the upper and lower parts. The lower tract that we're going to discuss first is going to be including your trachea, your bronchi, and your bronchioles. So there is a quick diagram of where they kind of separate between the upper and the lower respiratory tract. So essentially the lungs in the lower, the upper is more your throat, your nasal cavity, your nasopharynx, that kind of thing. All right, as far as what we have in place to help protect our respiratory tract, there's nasal hairs, mucus lining, IgA antibody, secretions. Some of those respiratory secretions also contain lysozyme, things like that. So all of this is at play to just try to help protect our respiratory tract from infection. So anytime that an infection happens is because that bacteria or that organism essentially has overcome those host factors. And a lot of times they will overcome them, or it's your own normal flare that have flared up in an opportune time if they will be able to. So those micro factors that they have, adherence, toxins, growth, avoidance of host response. So we all know that bacteria have lots of different virulence factors to help them promote their cause of disease. We've learned that about several of them. So let's actually get into the infections that we are concerned about. So infections in the lower respiratory tract, first and foremost, we have acute bronchitis. Typically, this follows an upper respiratory infection. Just so you know, URI is upper respiratory infection. So it can be part of that or it can follow it, but essentially it's excessive fluid in your bronchi, so bronchitis, inflammation of the bronchi. So you'll definitely have a productive cough. What that means is you have mucus or phlegm coming up, or what we call sputum. Is anytime we talk about productive coughs, it's saying that they have production of sputum, that's phlegm. Sometimes there's fever, sometimes not. A lot of times acute bronchitis is just caused by viruses. If it is caused by bacteria, especially in children, it's typically Bordetella pertussis. So remember, Bordetella pertussis is whooping cough. And we can screen for that using a nasopharyngeal swab. If they're very young, like an infant, then your physician would collect a respiratory secretion kind of sample, but otherwise we can do a nasopharyngeal swab screening for that whooping cough. Chronic bronchitis is this is bronchitis over an extended period of time for at least 3 consecutive months. A lot of times this is due to maybe something that they have going on in their life that leads them to kind of be at more risk, and their lungs aren't the greatest to begin with. So some pathogenic bacteria, though, that are known to cause chronic bronchitis, there's 3 here: Haemophilus influenzae, Strep pneumoniae, and Moraxella catarrhalis. So when we've learned all of these, we have learned very much that they're associated with pneumonias, respiratory infections in general, so this shouldn't be any surprise that they're listed here. Bronchiolitis is the inflammation of the bronchiolar surfaces, typically coming from viruses, especially in those that are between 0 to 2 years of age. So wheezing, cough, respiratory distress is a big worry there with watching children for their respiratory distress. So the biggest cause here, especially in that 0 to 2 year age, is RSV, respiratory syncytial virus. A lot of labs will have a kit that they can screen the sample for to see, get a quick yes or no that somebody's got RSV. So a lot of times it's just like a kit test. I know my daughter had RSV when she was little. Before she was a year old, they ran it on the kit test, came out with a quick pause. This has passed quite a bit through daycare systems. So there probably was somebody at our daycare that didn't know they had RSV yet, and then it was already too late and past it. Other viruses that cause a bronchiolitis would be influenzas, rhino and adenoviruses. Those are both your cold respiratory viruses to begin with. Parainfluenza has a lot to do with respiratory stuff as well. So you can collect through a nasal wash, and that's what they did on my daughter to screen her. And then, of course, pneumonia. So pneumonia is probably the biggest disease out of these, major cause of illness and death, especially in those that are already immunocompromised. So you can get this either just community acquired or being within a hospital on a ventilation system. So kind of a nosocomial situation, if you will. All right, so lots of different pathogens that lead to pneumonia. So you have some ones in here that you should recognize: Haemophilus influenzae, Staph aureus, Strep pneumoniae. Strep pneumonia is the #1 cause of pneumonia, so very popular. Klebsiella pneumoniae, that's named for what it does. Pseudomonas, especially with cystic fibrosis patients. They cause the nasty lung infections in those cystic fibrosis patients. Same with Burkholderia was the other one that caused a lot of lung infections with cystic fibrosis. Going back up, we also have Mycoplasma pneumoniae. When we discuss that, remember, it's more of a milder form of pneumonia than the rest of them tend to be, so it's something we kind of like walking pneumonia. A lot of times people don't even know they really have this. They don't have as many of the symptoms or as or don't feel as ill as some of the other pneumonias will. Let's see, I skipped Legionella. That's the Legionnaire's disease, right, with the coming through air conditioning systems, giving a lung infection there. And then, of course, you have viral pneumonias, influenzas. That's a big bad boy that we talk about every year. They screen people and run kit tests to see if people have influenza. That's why you get your shot every year to try to prevent it, hopefully. There's lots of different types of influenzas out there, so they do the best they can to figuring out which type might be that year. Adenovirus, cytomegalovirus causes a pneumonia-like illness. RSV is mentioned here again, so you have your whole list there. And of course, there's also fungal agents, fungal organisms that cause pneumonia, and even parasitic lung infections. So, all right, pleural infections is just anything that can occur after a primary infection and lung will affect pleural. As far as specimens go, we are going to collect what's wrong with them. So if they're having a productive cough where they're actually coughing up that phlegm or sputum, let's collect the sputum and test it. So that will have in it what is, we can grow out what's actually causing the pneumonia. We can grow it out on agar plates and determine their actual pathogen. So sputum, the biggest thing here is making sure it's truly quality sputum sample from deep in the lungs and not just saliva or spit from their mouth. So nurses will typically collect this. They give all the instructions to the patients. But our job when we get the sample is to make sure it's a good sample. So the very first thing we do on any time we get a sputum sample is gram stain it. And gram stain is going to tell us, yes, it's quality sputum, or no, it's not. So usually we're looking for lots of neutrophils, because anytime you have a bacterial infection, you will have neutrophils, high amounts, because that's what they fight is bacteria. So you should see a ton of neutrophils in the sputum, and then you should see very little epithelial cells, because epithelial cells are coming off the skin or inside like the cheek lining. And if this is truly a sputum from the lungs, you won't see any epithelials. If this is just spit from their mouth, then you will see a lot of epithelial cells. So we want to see little, because that will tell us it's a good deep lung sample instead. And then there, you will also see some bacteria on there. So typically you can report, oh, I'm seeing grandpa's diplococci. That's starting to make you think maybe it's strep pneumoniae then. Or, oh, I see gram-neg rods. You know, maybe it's one of those gram-neg rods like Klebsiella or something. But that's kind of what you're reporting out in a sputum on a gram stain right off the sputum sample. We're checking the quality. We're also getting a heads up on if it is a good quality, what gram stain is present, so the doctor kind of has an idea for antibiotic treatment as well. So again, first morning cough is the best with sputum sample collection. If you've ever been sick with a lung illness, or I've had pneumonia, I know that when I wake up in the morning, oh, I'm coughing up some good stuff. So it's usually easier to get the sputum sample then. All right, there's other specimen collections that you can do, tracheostomies. We treat it just like sputum when it gets to the lab, but it's done by a Lucan's trap. Those page numbers, I think, were for the other book. I don't think that's the right page number anymore for this book, so you can ignore that. Bronchial washings. You still have the chance to have upper respiratory contamination here, but there's that tracheostomy here, since you can ignore this number here, but here it is what it was supposed to look like. So it's showing you that Lucan's trap there. Obviously, this is not anything that we do. And then bronchoalveolar lavage, this is really good, especially if you think you do have a fungal organism. All right, this talks through that gram stain of sputum, again, evaluating quality. Ideally, we want to see less than 10 epithelials per low par fields and greater than 25 PMNs, which are just neutrophils on low par. That is going to say, yep, great sample, we're going to be good with it. So this is just showing you kind of what you might see when you gram stain. Letter A is showing you neutrophils. All those little pink guys are neutrophils. If you were able to zoom in closer, you'd see that they have the lobed nucleus inside the cells, and that obviously is a neutrophil, right? Lobes to the nucleus. Squamous epithelials are seen here in letter B in the background. They're very large with just a single nucleus in the kind of the center area. Lots of cytoplasm. So when you look at B compared to A, much larger cells. And again, in A, that nucleus is lobed, where in B, the nucleus is not lobed. So you can kind of see that. And then in B, it's showing you, oh, it did have some, it looks like Grandpa's coccyx here on it as well. All right, if we think we have a mycobacterium organism like tuberculosis causing a pneumonia or lung infection, that we can acid fast stain. So we just talked about this very recently. I'm not going to cover it, but we know the 3 acid fast type things that are going to really target mycobacteria. Sometimes if we do think it's like cryptosporidium, which is a parasite, we a lot of times use an acid fast stain looking for cryptosporidium on that as well, or Pneumocystis carinii. They now include Pneumocystis in the fungal group. I always, when I learned it, included it in the parasite group, but they've switched it to the fungal elements. Pneumocystis carinii is I should say that, highly seen with HIV or AIDS patients typically. So again, these are all things that we use acid fast stain looking for. All right, as far as what cultures or agar plates we're going to set it up to, of course, blood agar, because blood agar grows pretty much everything. And of course, chocolate agar. Chocolate agar grow our fastidious organisms that are a little picky. And because Haemophilus is such a big cause of pneumonia and even Neisseria, looking for it sometimes, we want to grow chocolate agar because that'll help grow those out. MacConkey agar, since there are some gram-neg rods here that are at play, like Klebsiella, Enterobacter, Acinetobacter, we could definitely set up a MacConkey agar plate as well. As far as if you really think you have Legionnaire's disease, remember there is a specialized agar just to screen for that Legionnaire's called BCYE, so that'll help screen for Legionella. I'm now going into the upper respiratory part. So upper respiratory system is going to consist of your epiglottis, that is essentially the little flap that closes over your airway, your larynx, which is your voice box, your nasal cavity, and your pharynx, which is your throat, and then you can have a few combination areas there. So again, there's a nice zoomed in picture of where everything is located, so just kind of keep it in mind. So we'll start with the disease of laryngitis, which is basically when you lose your voice. It's an infection of your voice box. Pretty much just viruses that are responsible for this, so it's kind of a, you just have to wait it out game. There's not much you do for treatment or anything. It's just wait it out. I've had laryngitis, lasts for like a good solid week at least. Yeah, it sucks. It wasn't, for me, it wasn't really painful unless I really tried to strain my voice, but it was just waiting it out, taking the virus time and taking your body's time to fight it. So influenza, parainfluenza, rhinovirus, adenovirus, coronavirus, these are all respiratory viruses. Your rhino, your adeno, and your corona had a lot to do with colds and stuff like that. So these are all very much respiratory type viruses. Laryngotracheobronchitis is what we call croup. Croup is that really harsh barking cough that young children get. Again, there isn't a ton to do like drug-wise. A lot of times they'll just watch their respiratory, their breathing, and put them in sometimes in a respiratory tent. And it's just really watching how they're breathing, making sure that they're breathing okay and things like that. So parainfluenza is probably the #1 cause of croup, but you also have influenza, RSV, and adenoviruses at play here. Epiglottitis is an infection or inflammation of that little epiglottis flap. Because that flap can become inflamed with this, it really can obstruct the airway, which can become life-threatening to the patient. Typically, we see this with younger children, 2 to 6 years old. So the #1 cause of that is Haemophilus influenza, especially type B. Again, we have a Hib vaccination that we give to children. We talked about this back in Micro 1, but that Hib vaccination was given primarily to ward off meningitis that Hib also causes, but on the plus side, it will also help prevent epiglottitis, so that obstruction of that little flap. Strep and staph can also do this, but again, Haemophilus influenzae was our biggest cause at one point. Pharyngitis, which is sore throat, lots of different viruses here play all the same type of respiratory viruses, and then the big bad boy bacteria, of course, is Strep pyogenes causing strep throat. Rhinitis is your cold, so again, all your same kind of respiratory viruses there as well. Other things, Cranibacterium diphtheriae causes diphtheria. Remember, that's that whole membrane across the back of the throat. That's a hallmark classic sign, is that exudative membrane on the back of the throat. Again, it can really cause problems with breathing. So that's being caused from the diphtheria toxin. Bordetella pertussis, again, whooping cough. Klebsiella, talked a little bit about it for pneumonia, but it also has something to do with rhinoscleroma, which is just a disease of the nose. I'm not going to really test you on that one, so you can kind of ignore that. Stomatitis is inflammation of the mucous membranes in your oral cavity. Herpes is a big cause of this. Thrush is caused by candida yeast, if you will, basically oral mucosa white patches in your mouth. And then periodontal infections, a lot of anaerobes come into play when we talk periodontal. So all of those are listed there for you. Pretty much almost all anaerobes can cause periodontal. I think if you notice, the only one really missing is Clostridium. And then Eikenella cordens. Remember, Eikenella cordens is that one where comes from human bite wounds or fist wounds, like if you punch somebody in the mouth because it carries, it's carried in our mouths. If you go punch somebody like a clenched fist wound and they have the transfer into the open abrasions on that fist, it can result in Eikenella cordens. Salivary gland infections, basically parotitis, inflammation of the salivary glands. The primary responsibility here is from mumps. So that's the main viral agent that causes that. Otherwise, Staph aureus is probably your major bacterial organism. Neck, again, and these are going to be anaerobes that are most common to cause infections within the neck. As far as samples, let's again collect what you're seeing wrong symptom-wise. So if you think it's an influenza type situation, RSV type, whooping cough, any of those, all are collected through nasopharyngeal swabs. So basically, it's a small swab up the nose and you twirl. You can do other collections, nasal washes. It depends on the age of the person, of course. But if it's an older child to adult, nasopharyngeal is the easiest way to go. Remember, with Bordetella, there's a couple specific transports, Reagan-Lower, Jones-Kendrick, that really help with that. And then culture-wise, sheep blood and chocolate, again, that'll pretty much grow all of it out. You want to throw a bacitracin disc on that sheep blood agar just because Strep pyogenes is something we see commonly in the upper respiratory infection world. So that'll help kind of start to screen process for Strep pyogenes. Bordet can go if we think it's whooping cough, if we think it's any sort of Neisseria, say or Martin Lewis, if you think it's diphtheria, Leffler, cysteine, tellurite, Tinsdale are all great ones there. And then again, anything that's periodontal or neck or anything possibly anaerobe, you always want to make sure you set up an anaerobic plate as well to screen for those anaerobes. Eyes, ears, and sinuses, so just a little bit further on here, anatomy of the eyes. Of course, we have eyelids, conjunctiva, sclera, which is the white of the eye, and your cornea. So any of these can become infected. You can also have infections within the internal structures, such as your aqueous or vitreous humor, and even an infection in your lacrimal system, which makes tears. So different diseases, we have blepharitis, which is inflammation of your eyelids, pretty much just caused by Staph aureus. Conjunctivitis is probably the biggest disease out of the eye area, and this is inflammation of the conjunctiva. Lots of different things here, but if you go down the list, a lot of these are the respiratory guys: strep pneumo, Haemophilus influenzae, Staph aureus, strep pyogenes, Varicella, Varicella is just a lot of upper respiratory stuff. Cranibacterium, so a lot of these are respiratory linked anyway, so we see this over and over again throughout this whole PowerPoint. And then you have a couple others. When we first learned about chlamydia and then gonorrhea, both of these were at risk of potential eye infections as well, as a side, kind of a side effect of having it, if you will. All right, keratitis is inflammation of the cornea. Again, aureus, strep pneumoniae, varicella, and you have a couple others listed here, Pseudomonas aeruginosa. Chorioretinitis and uveitis, inflammation of the retina and the uvea. So we have some treponema, which is syphilis, some spirochetes here, Borrelia. You have yeast, candida, Toxoplasma gondii, which is a parasite, and mycobacterium. So for collection-wise, they are going to have a sterile swab for conjunctivitis, or they can do a scraping of the cornea if they think it's a keratitis situation. And then we are going to plate it to pretty much everything. You can even throw on a CNA or a PEA plate. Direct gram stained right away to view what's going to basically kind of give the doctor a heads up of what you see on there. Because when you get eye cultures in, it should be pretty pure. You shouldn't have a lot of normal flora contamination. It should be, if they did a nice quality collection, it should be only really one thing growing out, whatever is the problem, you know. So whatever that pathogen is should be the only thing really growing out there. Ears, 3 parts, external, middle, inner. Otitis externa, remember we talked about Pseudomonas aeruginosa with this, that's swimmer's ear, which is an external ear infection, otherwise Staph aureus, strep pyogenes. The middle ear is probably the most common out of the ear infections that we see. Again, all of your same respiratory guys, Haemophilus, strep pyogenes, varicella, Staph aureus. And then you do have a couple viruses as well that can cause otitis media. And then you can get a swab, you can get a needle aspiration for your sample collections, and again, same type of plates, and again, a direct gram stain. And then sinuses. For acute sinusitis, there is different, same guys here, strep pneumo, Haemophilus, varicella, Staph aureus. Some anaerobes can cause it here as well. So again, set up all the same stuff, direct gram stain, and then you can even add on the anaerobe plate. All right, so that is the infections of the respiratory tract. The good news is you already have learned all of these bacteria. So none of these bacteria, unless you've just forgotten it, should be a shock. I mean, these are all ones we've learned. When we learned them, we linked them with respiratory stuff. So I know it's hard to be like, well, what one was that, one was that. If you just remember in general which ones cause respiratory, that alone helps you. Now, there are some additional virus stuff in here. We haven't played too much with viruses. But again, there's some main respiratory viruses that are always seen. So we repeated those names over: influenza, parainfluenza, RSV, adenovirus, coronavirus, rhinovirus. Those are your main respiratory viruses that get involved. So hopefully that should become simpler to realize. And then plates, you plate what you think you're looking for. Right now, we just basically started. Instead of learning the bacteria, now we're learning the infections and applying the bacteria backwards. So we're just kind of flipping how we learned before. So now we're looking at different systems in the body and applying what bacteria we knew were problem children. And that's kind of what you do in the lab is when you get a sample in, a culture in, right away in your head, you should have an idea of different pathogens that you're looking for. So if I get a like a sputum sample in, I'm right away thinking, okay, I could be looking for Haemophilus, I could be looking for Staph aureus, I could be looking for a couple different gram-neg rods like Klebsiella, Enterobacter. I could, you start thinking of strep pneumo, like kind of what your main pathogens are in that area. And so that's kind of what you're screening for, and that helps you set up your plates as well. You know what they like to grow on. So don't try to get too overwhelmed with it. I know it seems like a lot of info, but it's truly all stuff we've already kind of learned. It's just being applied differently. All right, and then going to the next one, this will be a nice shorter PowerPoint for you. So this is infections of the skin and soft tissue. Of course, let's review our normal flora on our skin. We have the diphtheroids. Those are basically Cranibacterium rods, not the big bad boy Cranibacterium diphtheriae, which is definitely a pathogen, but the other ones, the ones that are just normally found. They're just little grandpa's rods that you see show up that are like, oh, those are just diphtheroids. They're just normal flora on your skin. Staph epi, of course, is a big normal flora. Other coagulating staph as well. Propionibacterium acnes. You can even add in some bacillus species here, are normal flora of the skin. So different skin infections, you have folliculitis, which is an infection of the hair follicles. Staph aureus is probably the biggest cause here. Enterobacteriaceae bacteria can cause, and Pseudomonas aeruginosa, again, picking it up out of those moist, hotter temperatures like hot tubs, warmer pools, things like that. Pseudomonas thrives in that stuff. And then infections of the epidermis, this is pretty much those dermatophyte fungi, which we learned back in week 1 in mycology. Cellulitis, that's something you definitely see. Staph aureus is a huge cause of cellulitis. A lot of times, these people get put on IV antibiotics treatments. They'll come and get put on an IV treatment just because it can become systemic and nasty fast. So they kind of treat it very heavily that way. So Staph aureus is a big cause. I see that a lot with cellulitis, strep pyogenes as well. And then I spelled that wrong. Erysipelathrix rhiziopathiae. That was a gram-pos rod that causes erysipeloids, which were like big skin ulcers from handling animals. Necrotizing fasciitis is eating through the layers of the fascia, the muscle. Different strains are capable of doing this. Strep pyogenes, Staph aureus is capable. And then you have some nasty anaerobes like Bacteroides, Clostridium, especially Clostridium perfringens with the Gascane green and all that. And wound infections. Let me just tell you that any bacteria truly can become a wound infection. If you have a wound and the bacteria gets introduced into it, it has a possibility of causing a wound infection. So, I mean, the list just is endless. This is just an example of ones that we see commonly, but it's anything from bacteria to anaerobes to yeast. Anything really can cause a wound infection. So just keep that in mind. Just don't even bother memorizing a list. Just know that anything happens with that. And then media. Let's set it up to everything. Because we can look for so many different types of bacteria, starting with blood agar, chocolate, CNA or PA, and McConkey. That'll screen for everything. You can also throw in an anaerobe plate to make sure you screen for anaerobes. And then thio broth is just nice, enriched broth that will help support the growth of everything as well. In case something doesn't grow too well on the plates, it might really love to grow in the broth instead. So that will just take care of all of your needs, and that way, when you get in a wound infection, it can be generally anything. So anything that grows is going to be considered a pathogen unless it's contamination off the normal flora of the skin. All right, that is it for this week. If you guys have any questions, as always, please feel free to reach out and have a wonderful week.